So I would like to say something for Fadi Abillama, which is a really good friend of mine, coming from Lebanon. I would like to say that he's a professor, a chairman in the undergraduate preodontology program at the Lebanese University, and he is a former board member of the Lebanese Dental Association. His private practice is in Beirut, Lebanon. So Fadi, the podium is yours. We are waiting for you.
Thank you, dear Harian. And thank you, dear Matteo, for this lovely presentation. First of all, I want to thank Klockner Education, Spain, and DMS for this idea and this lovely webinars they are doing. It is really a big pleasure to be with you all today live. We sure are going through a hard time, not only in Spain and Lebanon, but all over the world. But sure, we are going to get through this situation, hopefully soon. My presentation today is about immediate implant placement, anterior and posterior regions. Lots of publication started in the late 80s about immediate implant placement, but at that time we had lot of, can I have the screen of my, instead of Harian, please? Yeah, so lots of publication about immediate implant placement started in the late 80s, but at that time we had a lot of complications. But we learned a lot from these complications. This is why this technique was criticized, and a lot of discussion if we should or not do immediate implant placement. This is why I'm going to focus today how to do this technique in the right way to avoid this complication. Because if we have this complication, at the end the implant will survive, but the problem will occur at the level of our tissue, especially soft tissue, and the patient will not be satisfied after this treatment. And then don't forget that an implant patient is married to our practice all our life. And we are going to discuss a little bit about dimensional changes in aesthetic in aesthetic post-extraction socket. We all know that we have bone alteration and we have soft tissue alterations. And a lot of studies showed, especially one from Sharp in 2003, that we have 50% reduction in width after extraction. And we have also 5 to 7 millimeter of horizontal ridge reduction that occurs between 6 and 12 months. And we have 2 to 4.5 millimeter vertical reduction that accompanies the horizontal changes. Arujo in 2005 also showed us that if we leave a socket to heal spontaneously, we will witness a buccal bone resorption of about 2.2 millimeter after 8 weeks. And this is very important to know before any treatment we are going to perform. There is 3 modalities of treatment after extraction. First of all, we can wait for 3 or 6 months for the hard tissue healing. It's a delayed implant placement. Or we can wait 4 to 8 weeks after soft tissue healing. It's early implant placement. Or we are going to place immediately implant after the extraction, and this is immediate implant placement, and this is our topic for today. And believe me, if we are going to discuss these 3 modalities with our patient, for sure he will choose immediate implant placement. Why? Because for him it will be less surgery, less time, and less money. And especially when we do immediately our temporary crown, or a provisionalization. IPP, with a lot of publication showed that this temporary crown will help to maintain our tissue, soft and hard tissue, in place during the healing, and to get a very good, and we get very good, predictable, and aesthetic and stable result. This is why immediate placement and immediate loading are the least invasive, most conservative approach to tooth replacement and site retention. As I told you, in the 80s and 90s, we had a lot of complication when doing immediate implant placement. So lots of question was, especially if this technique is unpredictable, if it's uncomfortable, it's stressful, or always it will lead to a recession or a bone resorption. From that time, we changed the technique. We are doing it not same as we were doing it in the 80s. This is why we have better result, and we are going to see what we are doing now for having these good results. But first, we have a checklist to be made before our implant placement. First of all, we have to see the type of biotype we have. If we have a thick biotype, like the one on your right, for sure, and a lot of studies also, like study of Chapuis, showed us that in this kind of biotype, because we have a thick buccal bone, we don't have lots of resorption, and it's safe to do immediate implant placement in this kind of patient. But when we have a thin biotype, we have to be more careful, and sometimes we have to do simultaneously connective tissue graft to have a nice aesthetic result at the end. We have to check our interdental bone. This interdental bone is very important because it will help restore our papilla at the time of the final restoration delivery. So we have to make a traumatic extraction to keep this interdental bone in place. We have to check also the distance between the facial gingival margin and the buccal bone. If it's 3 millimeters or less, it is safe and favorable to do immediate implant placement. If it is more than 3 millimeters, we have to be careful. And in this case, we can do maybe immediate implant placement, but we need more surgery to be done simultaneously and not always have predictable results. What about alveolar housing? Khan in 2010 did a classification for the alveolar housing. For him, he had 4 classes, and this is how the root is positioned in relationship to the premaxillary housing. In your opinion, which one of these 4 classes is better for immediate implant placement? The class 1 is the best for immediate implant placement, but why? Because we are going to use the palatal bone for our immediate stability. And look at the amount of the palatal wall we have in class 1. Class 3 also is favorable for our immediate implant placement because we are going to engage our implant in the palatal bone. In class 2, we have to check if we have 3 to 4 millimeters above the apex of the root for our immediate implant, our immediate stability. In class 4, because the dimension, the buccal palatal dimension of our root is almost same as the dimension of our ridge, here it's a little bit difficult to have our immediate implant, immediate stability. So in most of the cases, when we have class 4, it's difficult to do immediate implant placement. What were we doing wrong in the 80s and 90s? Lots of publication, like publication of Paulo Antonio, and publication, also some publication of Tarno and other, recommended that we use wide diameter when doing immediate implant placement. And plus we have to position this implant buccally. For them, this will prevent the loss of the buccal bone, but this was wrong because Araujo also showed us that placing an implant immediately after the extraction will not prevent the 2 millimeter loss of the buccal bone. So this is why we had a lot of complication when we were using wide diameter implant and placing them in the buccal position. We had a lot of bone resorption. We had a lot of soft tissue recession. So this is why we had to stop this technique. Kahn in 2010 recommended that we have to go for narrow implant. We have to place our implant palatally. We have to have a gap between our implant and the buccal bone and graft this gap. And also Araujo showed that it was the only way to prevent the buccal bone loss is to place an implant and graft the gap with xenograft bone. And for Kahn also, he recommended to do a connective tissue graft simultaneously with our immediate implant placement. So in summary, look at your left. Look where we did our preparation. We did our preparation in the palatal bone. This is where we are going to place our implant and get our immediate stability. We are going to put small diameter implant. We are not going to put any more 5 or 6 millimeter implant. So how we choose our implant diameter? If we have, for example, a socket of 6 millimeter, and we know that we need about 2 millimeters for our gap, to have a gap, we should place maximum 4 millimeter implant. We are not using any more, we are using maximum 4.3 millimeter to replace a tooth and especially in the anterior region. So we have our gap of 2 millimeter, and when we have a thin biotype, we are going to do a connective tissue graft simultaneously. And we are going to graft the gap with a xenograft bone. And all this procedure, we prefer to do it flapless. And when we can, we are going to do immediately our temporary bridge or temporary crown. When we do this technique flapless with temporary crown or temporary bridge, the tissue, and especially the soft tissue, will be ready and will be stable after 3 months to place our final restoration. But if we do a flap, we have to wait more than 3 months. So we have always to start with anastomotic extraction, but we have always trauma when we are doing extraction. So we have to do a minimal invasive extraction. There is a lot of instrument can be used to do that. Here we are using the periotome. We are inserting our periotome in the periodontal ligament. It's not easy and it takes some time, but it will it will help widening the space between the root and the bone. The root will gain mobility and we can continue our extraction with a delicate forceps. In the case of molar, for sure we have to do separation. We cannot do minimal invasive extraction without separating the roots. After that, we are going to clean very well the socket. We are going to spend lots of time excavating, because in some case we do it for 5 to 10 minutes. We are going to use curettes, we are going to use burrs, we are going to do irrigation for disinfection. We have to have a very clean socket before starting the preparation for our implant placement. And only after that we are going to start preparation for our implant placement. We start with a round burr or our lance drill, then with our drill, and then we are going to place our implant. We have to make sure, because for the surgeon who tried this technique before, there is a risk that our implant will shift buccally, because it has the tendency to go towards the least resistant part of the socket, and that is buccal part because there is no bone. So if we don't place our implant in the position where we did our preparation, we will lose the 2 millimeter gap. And as it has been shown, we need this 2 millimeter to prevent the resorption of the buccal bone. After that, we are going to graft this gap. And if we want to do our temporary crown, we will connect our temporary abutment and finish with our temporary crown. All our implants should be prosthetically placed prosthetically driven. We cannot end with an implant placed like this one. It will be we cannot do the final restoration for this implant. We will be forced to remove this implant, do bone grafting, wait 9 months, then replace another implant, wait 3 months for our final crown, and the treatment will finish after 1 year. And remember, at the beginning, we told our patient performing immediate implant placement, it will take maximum 3 months to finish our treatment. Finishing in more than 1 year, it will be catastrophic for our patient and for our reputation also. So we have to make sure when we are placing an implant immediately in a fresh extracted socket, we have to put it in ideal position for our future restoration. So how we will get our immediate stability? If we don't place our implant in the palatal bone, we have to check if we have 4 to 5 millimeter apical to the root apex. And there we are going to have our immediate stability. But there is some anatomical limitation for that. For example, in the posterior maxilla, we have to check the location of the sinus floor, but still it's not a contraindication. We can always do extraction and place immediately our implant after doing an internal sinus lift. And there's a lot of study with high survival rates of implant done by this technique. At the mandible, we have to locate also our nerve, not to injure it during our preparation, and we have to check if there is a lingual concavity, not to have perforation during our preparation also. As I told you, the palatal bone is very important for our immediate stability. We are going to place our implant in this palatal bone. We don't place our implant in the socket, and we are not going to do preparation same direction as the socket. We are going to use this palatal wall. We are going to place our implant at the level of the cingulum, but we have to make sure that we are putting our implant, the axis should not be more than 15 to 20 degree facial to the incisal edge. What about implant morphology? All studies showed that it's better when we use tapered implant, we have better stability. But still, when we are using a parallel shaped implant, we have good stability, and it's not contraindicated to use parallel shaped implant. And we are using the Vega implant before having the Vega Plus with nice stability and with high success rate. What are the advantages of immediate implantation? First of all, we have reduction in treatment time, we have reduction in surgical intervention, and we have reduction in cost. This is what I told you. For the patient, it's less surgery, less time, and less money. And we have prevention of resorptive tissue changes, especially when we are doing immediately the temporary crown. The disadvantage of immediate implantation: optimal positioning is difficult, primary stability could be difficult, lack of soft tissue closure, presence of infection risk, and we are going to talk about it later, and still it's a sensitive technique. What about compromised sites? Lots of several studies comparing implant place in site where there is infection, there is purulence, fistula, radiolucency, with site with absence of periapical pathology, showed same survival rates of our implants and comparable outcome. So it's not a contraindication to place our implant in compromised sites. But we have to give antibiotic 2 days prior to our surgery. Some goes to 4 days prior to surgery. We have to clean very well the socket. In this case, we have to spend here lots of time, maybe 10 minutes cleaning the socket, irrigation for disinfection, and we are going to continue with our antibiotic 5 days after our surgery. This is a clinical case. A patient came to our clinic with a discolored lateral. When we examine the periapical X-ray, we have internal resorption of the root. Our endodontist told us it's a hopeless tooth, so we had to do the extraction. And we did our immediate implant. We placed our implant. We had 2 millimeter gap. We graft the gap, and we placed our temporary crown. Here we used the crown of the patient. It's a very nice technique to be used. We used his tools to do our temporary crown. And as it has been discussed, it will help to maintain our hard and soft tissue during the healing. And after 3 months, because it's as I told you, it's a flapless, the soft tissue is stable. We took the impression and we put the final restoration. And these last 2 X-rays are after 6 years of treatment. Look, when we are doing it right and we are doing immediate implantation placement with immediate temporization, how we manage to maintain the soft and hard tissue in place. Another case, patient came with 4 upper anterior teeth with severe resorption, bone resorption, and mobility. We did our for sure we are going to do our initial therapy first. Then we did the X-ray, and we decide to place an implant at the level of 11 and 21. Here we have 3 to 4 millimeter from the gingival margin to the bone to the bone. We start doing our drilling, and we placed our implant palatally, as we always do. And then we are going to graft the gap, and we are going to graft the socket for 22 and 12. Here, because we have a sick biotype, we are not going to do a connective tissue graft at the same time. And there is a study also for a Dutch team. For them, if we use only narrow implant placed buccally, and we do grafting of the gap, and if we do immediately the temporization or immediate loading, we even don't need this connective tissue graft. We will have a good and predictable aesthetic result even without doing our connective tissue graft. After placing our implant, we are going to do our temporary bridge, and this is the healing after 3 weeks. And this is the healing after 3 months. Look at the architecture of our healed gingiva. And gingiva is the tissue, our soft tissue is stable. We are going to take the impression, and we are going to deliver our final bridge. And this is the bridge after 4 years. look at the stability of our hard and soft tissue after 4 years using immediate implantation, immediate loading technique. This is also another case. It's a canine, it's a fractured canine. We did the extraction of this canine. This is a fractured canine. And here to show you that if we do it right, we are going to have a very nice result, even if you use a tissue level implant. And this is a Klockner essential implant. We place our implant in the socket, in the palatal bone. We are going to graft with xenograft bone, and we are going to do immediately our temporary crown. Here also, we did it flapless because we have a risk of recession at the level of the lateral and the premolar, because it's to count two teeth. And even before our surgery, look at the level of the gingiva on the lateral. It's higher than gingiva on the central, and we don't want to have recession after our implant treatment here. And this is a temporary crown. And after 3 months, look at the healing of our soft tissue. It's ready for our impression. We take as an impression, and this is the final crown. So even with tissue level implant, we can get predictable aesthetics and stable results. What about immediate implant placement in the posterior region? In the posterior region, we have the premolar region and we have the molar region. For the premolar region, it's similar when we have a one-rooted premolar, it's similar what we are doing in the anterior region. We are going to have our immediate stability from the palatal bone, or we are going to search for 3 to 4 millimeter apical to the root apex. When it's a two-rooted premolar, we are going to place our implant in the palatal root, or if we have a large interseptal bone, we are going to use this interseptal bone for our implant placement. So after extraction, we place our implant, do bone grafting, temporary crown, and after 3 months, we put the final restoration. And look at the amount of hard and soft tissue after 4 years. Really, it's a very predictable technique if it's used right. What about immediate implant placement in the molar region? Here, it's a little bit more difficult to place an implant immediately after extraction, especially when you have thin interseptal bone. And for the one who already tried this technique, the drill will slip. We will end doing our preparation more mesial or more distal, and we will not be able to place our implant where we wanted to place it initially. So, but before now, last 8 years, we have a lot of publication about immediate implant placement in this region, and with high survival rates of this implant placed immediately after extraction in the molar region. And we have it, in 2013, there is a technique described by Ribelli, Zur, and Hutzuler. And this technique was modified also by our friend, Dr. Antoine, in Paris. And we are going to show you how we are doing our implant placement to get to easily prepare the site for our implant placement. But first, we are going to see the classification of Smith and Tarnow in 2013. For him, it's type A socket when we place when our implant is completely contained within the septal bone. Type B socket is when it's not fully contained by the septal bone and there is a gap present between the implant and the inner socket wall. For type C, there is no septal bone available for implant stabilization. And of course, it's easy to place an implant in type A socket. It's more difficult to place it in type B socket. And sometimes we cannot do immediate implantation in type C socket because there is no bone around our implant. So what we are doing in the posterior region, first of all, we have to eliminate the crown. We have to remove the crown to have direct access to our roots. After that, we are going to do the separation of our roots, and we are going to start our preparation before extracting these two roots. Really, these two roots will help in doing our preparation. It's like drilling in healed ridge, and we don't do the extraction of the root before finishing our preparation. We finish our preparation, we do the root extraction, and we do our curettage, and look at our preparation. We are going to be able to place our implant where initially we wanted it to be placed. After that, we are going to put our bone substitute, and or we will put collagen sponge and do our suture, or we are going to do immediate temporization for these implants. This is some X-rays to illustrate our technique. So separation, preparation, extraction, and look at the quality of our preparation after the extraction of the roots. Really, it's a very easy technique to replace implant in the molar region. We place our implant and we are going to graft and close the wound. One small modification we did with Dr. Malouf, because when doing this technique, in some cases, when we have, especially when we have curved root, the preparation, in some cases, the preparation, we have thin bone, mesial or distal of our preparation. And when we have a curved root at the time of the extraction, we will compress this preparation and we will lose our mesial, our distal part of our preparation. This is why this small modification was done. For us, we do the separation, we do the extraction of the two roots, and we put them back in place. We do our preparation, and then easily we will remove them, and there will be no damage to our preparation. And then after, we are going to place our implants. And look, in 80% of the case, it's very easy to do our preparation for immediate implantation in the molar region. Really, it's a very easy technique when we adopt it. For upper molar, we know that we have 3 roots for this molar. We are going to do the separation of these 3 roots before doing our preparation. At the level of the 7, we did the extraction because it was a one-rooted molar and we could not do the separation. So we do the extraction. It's a type C socket, but still we could manage to do our preparation with a small internal sinus lift and get our mid stability. And so we place our 2 implants with bone graft, and look at the last 2 photos. It's the result after 8 years of treatment. And look at the volume of our soft and hard tissue after 8 years. So to finish, I'm going to speak a little bit about immediate loading or temporization, because in most of our case, we are doing immediate implantation. We are doing simultaneously immediate loading or temporization. And lots of study comparing site with immediate loading, immediate implantation with site with immediate implantation plus immediate loading temporization gave same success rate and same radiographic result. So it's safe to do immediate implant placement. And what we said before, it will help and maintain our soft and hard tissue during the healing and after our crown delivery. But we have to reduce the implant micromovement during the healing, of course. And what was recommended that we have to have about 30 Newton centimeter as insertion torque to do our immediate loading or temporization. We are using a penguin device to evaluate our implant stability. And for that, what was recommended that when it's splinting case or full rehabilitation case, we need the measure should be above 65. But for a single implant, the measure should be above 75. So we are evaluating with the penguin the stability of our implant to know if we can or we cannot do immediate loading procedure. So in this case, the patient lives abroad. He came to us. He wanted to start by doing full rehabilitation of the mandible. So we did the X-ray and we decided to place implant at the level of 36, 33, and 34, and the level of 46, 44, and 43. Always we choose to place six implants in the mandible to make three different bridge. We make a bridge from 46 to 44, from 43 to 33, and the last bridge will be from 34 to 36. We do three separate bridge for the lower as a final restoration. So we did the extraction, we placed our immediately our implant, we did the graft, and we did our temporary bridge immediately after implant placement. The patient didn't want to go out of our clinic without any teeth. Yeah, he knows for sure that he's going to eat soft food for about 1 to 2 months, but it will be more comfortable to him to go out with a temporary bridge. And this is the healing after 3 weeks, only 3 weeks after implant placement. The patient came back because I told you he was living abroad after 1 year, and he was very happy from his what we did in the at the level of the mandible, and he wanted to do the same for the maxilla. So we did the extraction and we did 8 implants in the upper jaw. And for sure, we immediately deliver his full temporary bridge. And before he is leaving, we did his different 3 we did his final restoration for the lower mandible. We did, as I told you, 3 bridges, and this is his 3 bridges in place with a temporary bridge for the upper one. And look at the stability of our bone after 1 year of treatment. And we are waiting now this pandemic to finish for him to be able to come back and finish the upper treatment. So immediate loading or temporization, what are the advantages of immediate loading and temporization? It eliminates the need for removal or provisional restoration. We have to stop using a removable denture or flipper as provisional for patient. This is not good. This, in some case, we will even lose the implant if we are using flipper or removable denture. And if we don't lose the implant, we will have problem with our soft tissue, and it will and the final result won't be aesthetic. So we have to do immediate loading, immediate temporization when we can, instead of using this removable prosthesis. With the immediate loading and temporization, the patient will be satisfied, and because he's going to go out from our clinic without any missing teeth. And as we discussed before, this will help minimizing the resorption and maintenance the pre-existing architecture of soft and hard tissue in most cases. So to end, what are the take-home message? We have to think 3D positioning of our implant. We have to place our implant immediately palatal position, to have a gap of 2 millimeters, to graft this gap, to do flapless technique, and when we can, we have to do our temporary bridge immediately with immediate implant placement. And lots of studies showed with these two techniques, we will have a very good aesthetic and stable result. So it will be a big yes for immediate implant placement, and a big yes for immediate temporization or loading. And thank you for your attention.
So thank you, Dr. Fadi Abillama. Congratulations for your presentation. Really nice, really brilliant, sharing the literature, also the cases, very interesting cases as well, as Matteo has presented as well. So there are many questions as well. So I'm gonna ask some questions from the public. The first question should be: how important is the thickness of the buccal plate while doing immediate implant placement?
As I mentioned before, when we have a thick buccal plate, it's very favorable to our immediate implant placement, because we know that we will not have resorption. If we have very small resorption of this buccal plate, and it will be very predictable in these cases to do immediate implant placement.
Okay. Another question should be: how cover the biomaterial placing the cap when you don't anything between the prosthesis and the bone?
I didn't understand your question.
So when you are placing the implant, and you are placing also the xenograft in this case, do you cover the xenograft, or don't you put anything between the prosthesis and the bone?
No, we don't do any. We don't do put anything. And I showed you the healing after 3 months. There was still some granules of the xenograft. We don't put anything. This temporary crown will help maintaining our xenograft in place, not to lose it after. In some cases, some people are putting collagen sponge, but I don't see any meaning for doing that.
So, because sometimes, for example, when you place the temporary prosthesis, also you have to cover the bone. Or don't you cover the bone? You place something when you don't place any temporary prosthesis?
As I showed, in maybe 90% of our case, we are doing immediate temporary. When we are not doing, we put collagen sponge, and we do our suture. And even when we do our temporary, we prefer not to do suture, even not to do compression, not to do anything. Only we put our temporary crown and we leave it to heal.
Mm-hmm. Another question is, do you recommend to change the shapes of the healing abutments in the course of the treatment in order to manage the emergence profile, for example, in the posterior side or in the anterior side? What would you recommend?
To change what?
Change the shapes of the healing abutments. Okay, you have a healing abutment like this, you can change it like this or whatever. So do you recommend it to change the healing abutments in order to shape better the emergence profile?
It will be better, yeah. But if you are using a temporary crown, you give the shape, the final shape of your crown, so no need to change after. But if you are putting, if you put your healing, it will be, in some case, we can do that.
In some case, I mean, in my clinical perspective, I think that the changing the shapes of the healing abutment don't give you any point, because you are disconnecting every time your healing abutment. In this case, I will wait for the healing of the osseointegration of the implant, and then I can change it with the prosthesis, the provisional prosthesis, for example.
So the question was to change it during osteointegration. No, we can change it, as you said, we are going to change it after the osteointegration if we want to change it.
If you want to change it, exactly. That's my point and your point as well. Another question that I would like, no, I think that all the were answered. So you have presented the Hurseler technique for the posterior immediate implant placement. This technique was described by Hurseler many years ago. And what is the advantage of this technique, apart from the immediate implant placement? For example, in a case with a type 2 ilion, for example, of a extraction socket, when you don't have any buccal plate or loss of 50% of the buccal plate, what would you do? Would you do this kind of implantation with the Hurseler's technique, or would you change your mind in these cases? What would you do?
If we have type 2, no, we will change our mind. We'll do the extraction, and we will do immediate implantation as we do it, as we did it before. But we can, if we want, do it with this technique also. If we locate our, if we do our sounding to see at the level of our bone during the preparation, if we want to place, for example, an implant of 10 millimeter, if we have 4 millimeter resorption, we can go to 14 to place our implant. So we can adapt this technique in all cases if we want.
Okay. Of course, if you have the bone availability to place the implant as well. What would you think about the implant topography in terms of placing the implant immediately or not? Do you think that for example, a more aggressive implant would help you to place the implant in those cases or not? Because
the connection is a little bit bad. What was
the topography? I mean, for example, the Vega implant is a cylindrical one, okay? But also the Vega, but in the other side you have the Vega Plus, for example, that is more aggressive in their spins, and then so. Do you think that this kind of implant would help you to place more adequately or easily the implant in those cases at the molar site?
Of course, now with the Vega Plus, we are placing more Vega Plus when we do our implant placement. Before we didn't have this Vega Plus, so we were using the Vega. But for me, using tapered implant is better when doing implant placement.
Perfect. So this is an indication of this kind of implant for the immediate implant placement. So another question that I have for you.
I wanted to show some cases and for 5-6 years follow-up. We didn't have the Vega Plus. We only had it maybe 5-6 months.
No, I know criticizing. I only discussing the options. Discussing the options, my friend. And you have showed some kind of different cases with different kind of implants. For example, some cases, as you have presented, the Vega cases are bone level implants. I mean, in general terms. But also you have placed tissue level implants in the immediate implant placement. It could difficult your implantation or your immediate implant placement with this kind of implants compared to the bone level implants. Do you think that it could have an impact or not?
Look, it depends. Some people, some surgeons, even with tissue level implants, they have a very good result. It depends if you work a lot, and for my friend Malouf, you know him,
exactly.
He prefer always to do tissue level implant. For me, I have better result, and I am more into bone level implant. I prefer to place bone level implant. It's easier, especially in the aesthetic zone. But still, as I showed, we have also with tissue level implant, if it's done, but we have to be more careful in the aesthetic zone with tissue level implants.
That's good. So there is the last question from the attendants. So one attendant asked that why did you place the front 2 implants in the central position, 11 and 21, instead of 22 and 12? Was it the bone thickness problem?
It was not the bone thickness problem. I prefer always to place implant immediately in the centers. First of all, I have a wider socket. So in this case, I placed a 3.5 millimeter because the socket was not more than 5 millimeter for the central. It was not more than 5 millimeters. So if we are going to place it in the lateral, we won't be able to have the 1.5 millimeter gap, and we will have a risk of bone recession after. So it's very small socket at the level of the lateral, but still, I always prefer to place our implant at the level of 2 centrals instead of placing it at the level of the two laterals.
So in addition, I would like to add something from the prosthetic point of view, because it's not always from the best perspective to deal with an emergence profile from the lateral incisors, that it's quite difficult that from the central incisors. So sometimes this was discussed by Francesca Bailati and Urs Belzer many years ago, and they published in one article discussing this. And even in some cases, they prefer to place, when they have the opportunity, as you have said, the biological situation to place with a really good gap without any recession, without have any recession, etc., etc., etc. They look for in those cases, we look for the placement in the lateral incisors. But in the most of the cases, because you can control surgically better in those, as you have said, in the central incisors than in the lateral one. So sometimes you have to deal with the situation, the clinical situation. They are quite different from one case to another. So I think it's the...
And plus, if you have a small mistake in placing your implant in the lateral, you will have a lateral larger than the centrals. So it's easier, as you said, to place the implant and to control it at the level of the 2 centrals.
Exactly. So my friend, very nice presentation, very nice discussion. Congratulate you for the presentation and also for the answers. So if we want to go for the next presentation, that is me in this case. So Thank you so much, Fadi. We will discuss later with Matteo all the presentations and to get the take home message.
Okay. Waiting for your presentation.
Thank you, my friend.